for the treatment of clear cell renal cell carcinoma, HIF-2α inhibitors, angiogenesis, tumorigenesis, and emerging agents. This activity is brought to you by CME Outfitters, a provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Merck Sharp and Dome Corporation, a subsidiary of Merck and Company Incorporated. Again, I am Shen Gao, Assistant Professor of Medicine at Harvard Medical School. I'm part of the Genital Urinary Cancers Program and the Developmental Therapeutics, or Phase 1 Investigational Program at Massachusetts General Hospital Cancer Center in Boston, Massachusetts. I am pleased to be joined today by Dr. Eric Yonash, Professor of Genital Urinary Medical Oncology, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Welcome, Eric.
Thank you, Shen. It's great to be here.
It's great to have you. So we'll dive right in. The learning objectives for today's activity are: 1, recognize the function of critical components of the VHL HIF-2α VEGF axis in regulating angiogenesis in cancer. And 2, to identify the potential value of HIF-2α inhibitors in the treatment of clear cell renal cell carcinoma. So we'll dive right in here into VHL disease manifestations, prognosis, and standards of care. And I want this to be a conversation with Dr. Yonash here. So please feel free to jump in if you have additional thoughts or comments at any point. So VHL syndrome is an autosomal dominant disease associated with loss of the von Hippel-Lindau or VHL protein function. It's characterized by the growth of cysts and or benign or malignant tumors in multiple organs. Hemangioblastomas occur in about 50% of all patients, and the average onset of disease presentation is 26 years of age. In terms of the meat of today's conversation, in terms of renal cell carcinoma, this manifests in about 40 to 70% of all patients with VHL disease. So VHL HIF axis aberrations drive cellular and microenvironmental changes. So in VHL syndrome and other VHL-driven diseases, loss or inactivation of this tumor suppressor gene VHL results in VHL disease. This is a hallmark of clear cell renal cell carcinomas, including sporadic cases of clear cell renal cell carcinomas not associated with germline VHL mutations. And in terms of all sporadic clear cell renal cell carcinomas, this inactivation of the VHL protein function occurs in over 90% of all cases. For management of VHL-associated renal cell carcinoma, traditionally, or in recent years, we've basically been using sunitinib or pazopanib, these VEGF-targeted tyrosine kinase inhibitors. And the response rates, unfortunately, are limited. For sunitinib, for example, the response rate is 33%, all partial responses. And 56% of patients do have stable disease on treatment. In terms of hemangioblastoma response rates, we unfortunately don't see any with sunitinib. With pazopanib, the response rate is 52%, with 3% complete responses and 49% partial responses. Again, only 4% response rate in patients with hemangioblastomas.
Yeah, thanks, Shen. That's a great summary of VHL disease. And, I think you've very nicely pointed out the two major areas of concern for these patients is the hemangioblastomas and the renal cell carcinomas. And I think paradoxically in 2021, probably the hemangioblastomas are the ones that cause the largest amount of morbidity and potential mortality. And as you point out with sunitinib and pazopanib, and those are two studies that we did, we did see shrinkage in renal cell carcinoma. We saw substantial toxicity. We really didn't see a tremendous amount of efficacy. I mean, modest with pazopanib, and it's clearly a place where we have room for improvement.
And can you comment, Dr. Yonash, in terms of say before belzutifan's recent approval, were these agents that you were using routinely in patients with VHL syndrome?
We did use pazopanib. Sunitinib ended up really being an agent where patients, if they were given the choice between being on sunitinib or having a surgery, that frankly were preferring surgery. Pazopanib did really result in stabilization. For example, in hemangioblastomas, we did see, if you look at the waterfall plots in our paper, then you see that there was probably more than half of the patients had some degree of shrinkage and stabilization. Individuals where there weren't any surgical options anymore for hemangioblastomas, we were able and are still stabilizing several individuals. But you're dealing with the hypertension, you're dealing with the hair whitening, you're dealing with the nausea, the transaminitis. I mean, it's not a super easy road, but it was something and is something that we're still using in a subset of patients.
That's really helpful. Thank you. Thank you for that insight. So maybe we'll move on to a case study as, sort of setting the background for how to manage VHL disease associated RCC and jumping into the data for belzutifan. Okay, so here's our case study number 1. We're talking about a 35-year-old woman who has a family history of VHL disease. Her creatinine at this point is 1.6. She has established retinal hemangioblastomas, small pancreatic neuroendocrine tumor, and multifocal renal cell carcinoma, with the largest measuring about 2.5 centimeters. She's had prior surgery for renal cell carcinoma, and now she comes to find out about non-surgical options. So I would say a pretty typical patient with VHL disease manifestations.
Yeah, great case and a great example, Shin. This is the sort of individual where they've already had multiple prior surgeries, and they're really, both the patient as well as the surgical team and the treatment team is starting to get a little wary of yet another procedure. You go to surgery number 3 or surgery number 4, and you start getting scarring, you start getting issues. You can do ablation, but that creates further scarring. So these patients, this is something I'm facing in my clinic all the time, where these people really are looking for a way to manage their disease without having to submit to another procedure. And so what we're going to be talking about today really are some systemic therapy options. And there's a class of drugs, HIF-2α inhibitors, of which belzutifan is the one that's approved. But there's clearly, I think this is a paradigm that we're going to be seeing is going to be exploited by a number of different companies in the very near future. There's looking at the HIF-2α protein. There's a cleft in the PAS-B domain where you can actually get a small molecule to stick. And what's important about that is that HIF-2α being a transcription factor, it needs to heterodimerize with HIF-1 beta to then actually go into the nucleus and transcribe things like VEGF, as well as the other metabolic and pro-survival factors you were talking about before. And it's been extremely hard to do. Belzutifan, or MK-6042, does look like it was doing this, and it in of itself had to, was a second generation version of a drug that was originally developed by Peloton and is now being marketed by Merck. And let me talk a little bit about the study that we did here, a very interesting little registrational study. So because of the rarity of VHL disease, we were able to actually do a single arm study. Originally was powered for 50 patients to observe response in renal cell carcinomas and VHL disease. And so the eligibility criteria were, basically VHL disease, genetically confirmed, no prior anti-cancer therapies, and a renal cell carcinoma at least 1 centimeter in size. And the primary endpoint was objective response rate in these VHL-associated tumors. And then the secondary endpoints, and we worked very hard at the beginning when we designed this trial to make sure that that independent review was being done of hemangioblastomas, of pancreatic neuroendocrine tumors and other manifestations, sort of with the fingers crossed hope that we might actually get a broader indication for treatment of these as well, which we did actually. The primary endpoint of this trial with 22-month follow-up was objective response rate in the renal cell carcinomas of 49%. It's confirmed. There are some unconfirmed no CRs, which is, I think kind of what we're going to be getting with this drug. Nevertheless, the vast majority of patients, close to 90% of the patients, remained on study, and very few came off. And in looking at the abstract that was presented at ASCO this year, the waterfall plots, you can see that really there was no patient that had growth. 92% had decrease in target size. There's a swimmer's plot that sort of shows that patients, for the large part, with a few exceptions, remain on study. And there's also a figure where what we did is we looked at the number of interventions prior to starting belzutifan versus after. There was an average of about 20 per year pre-initiation in the 61 patients, across all patients. And then after initiation, there's been 3. So it's really kind of, I think, a striking thing. And the other thing that we see is the efficacy extends to hemangioblastomas, 30% objective response rate in hemangioblastomas. Pancreatic neuroendocrine tumors, small numbers, 22, but 91% objective response rate. So pretty cool results. And we also see this with retinal hemangioblastomas. I'm a little biased because this is obviously a study I've been very involved in, but what do you think about these data with regards to, VHL patients?
Yeah, I think that's a really great summary, Dr. Jonas. So, I think the data is really quite impressive. Obviously a smaller study, but you're required to do that with a rare disease population. But really, I think uniformly you can see, as you pointed out, every single patient has some degree of tumor shrinkage, essentially. And what struck me about the swimmer's plot, and maybe I could get your thoughts about this, was that some of these partial responses, like the first time that patients hit a partial response, was quite a bit delayed than what we often see with other therapy types. Where we can see that a good number, and really the majority of patients had reached partial response only at 6 months or 8 months, or even more than a year out.
Yeah, a very, very good observation. And yes, this is the kinetics of response with this agent are different. It's true for VHL disease, and also, we have a lot of experience with this now in metastatic renal cell carcinoma. This is a slow, steady, but continued response pattern we're seeing with this drug. And it's quite different from TKIs, where you end up getting the vast majority of your reduction probably within the first 2 to 4 months. Here we're seeing that there's ongoing improvement in a subset of individuals. And I'm still seeing this in some patients that have been on for more than 2 years, continuing to see some slight shrinkage. So great observation. And it just speaks to how different this agent is from TKIs.
Yeah, and I think you mentioned earlier, we didn't see any complete responses with this agent, and maybe we never will. Do you see a situation where some of these patients will continue to have ongoing tumor shrinkage? Some of the PRs may ultimately convert to a CR, or do you think that's wishful thinking on my part?
I wish that what you're thinking will have come to pass. I'm not certain for renal cell carcinomas whether that's going to happen. For hemangioblastomas, we are seeing it. So it is kind of interesting. We're seeing that those do have complete disappearance radiographically, but I'm not sure whether that's an artifact of imaging, where because these are no longer, the angiogenesis in those has changed in a way that they're just quiescent, and if we were to stop, they were just basically to pop up again. But I'm not expecting complete disappearance, but I am anticipating long-term stabilization.
That's great. Certainly it seems like the vast majority of patients did benefit, at least to some extent, from this therapy in the study. So why don't we move on to the safety and sort of tolerability data of this agent? Because as you showed, some of these patients have remained on the study treatment for a very long time. And so in terms of the safety data from the initial study here, we can see it summarized in this table. Any grade adverse events, occurred in 100% of patients. Although when we look at the treatment-related grade 3 or higher adverse events, it was really only about 15% of the population of patients studied. AEs leading to treatment discontinuation only occurred in 2 patients, so 3%. In terms of treatment-related adverse events leading to treatment discontinuation, it was actually only 1%. So it does, to me, just sort of from a 30,000-foot view of the safety data here, it does seem like this may be a drug that is better tolerated in general than our TKIs. What are your thoughts, Eric?
Yeah, I agree. And the most common AEs that we did see were in the subsequent table, where we do see that anemia, which is an on-target effect because EPO is a client gene of HIF-2α. We almost kind of welcome seeing it, but it is something that it exists, as well as the other really important one is hypoxemia. And it is, I think, in the real world, something that we're going to have to be very, very aware of. And we think that what happens here is it actually, that the pulmonary vasculature is probably regulated by HIF-2α. And what you get is you get a functional VQ mismatch, ventilation perfusion mismatch, that results in hypoxemia. And paradoxically, some of my patients have told me that their oxygenation, if it goes below 90%, the best way for them to raise it is to go for a walk, which is completely opposite from what we're seeing with like IO toxicity. But it really speaks to the fact that this is just basically physiological dysregulation. And so, from a side effect management perspective, there's anemia. The package insert for belzutifan does not recommend erythropoiesis stimulating agents. This is I think somewhat controversial and probably in evolution. And the other thing really, I think, is in the hypoxemia. And what I've told my patients is to basically go online and order pulse oximeter. And I actually ordered one myself last week, and I got one for $14.99. And it works just fine. So, it's not a huge cost outlay, and it's something that you can have. And it's really, really important for the patients to monitor that.
And can you clarify, Eric, then, in terms of the hypoxia, is that typically associated with dyspnea and other symptoms, or is that kind of a pulse oximeter or vital sign finding alone?
It can be a vital sign finding alone. So I think it's really important for patients to be able to proactively manage that and talk to the team about it. But it can be associated with symptoms as well.
Anything about this particular slide, Dr. Jonesh, that stands out to you or that you'd like to highlight?
No, I think you've done a great job, Shin. And as we talked about before, I think it's an ongoing dialogue between the patient and the treatment team. And this is, not a drug that you can basically just prescribe and then talk to the patient 3 months later. These things need to be actively managed. One of the things we've done is there's a consortium of centers, yours is one of them, that we've come up with a consensus on how we actually draw blood and follow these patients. We do baseline hemoglobins, the initiation of treatment. We do iron studies just so we verify what's going on from that standpoint, from a covariate perspective. We follow these. We see these patients with a video visit or a phone call or whatever monthly CBCs. And have the patients basically monitor their hypoxemia. We really want to make sure that we capture these things as they're occurring.
And are you able to comment on, is there a typical time course for when these side effects start to develop, or is it sort of, it could really develop at any time? Is there a more common period?
So the anemia, it's hard to know because we don't, we're not following the anemia as closely in terms of like doing weekly CBCs, but it is something that will develop over the first month in the patients where it will be a problem. Less commonly, it'll be a later thing. The hypoxemia can be within days.
Yeah, so certainly something to monitor very closely, given how quickly some of these side effects can develop. All right, so let's get back to the case. Again, just to review, 35-year-old woman with VHL disease, elevated baseline creatinine, and has prior surgeries for RCC, as well as a number of other manifestations of VHL disease. And so at this point, Dr. Yonesh, the patient comes to you and she asks, what are my options and what do you think is my best option? Should I read about immune checkpoint inhibitors? Should I think about pazopanib or sunitinib, or are there clinical trials that you would recommend?
Yeah, so interestingly, again, there's very, very little data on the use of immune checkpoint inhibitors in the frontline setting in individuals who have VHL disease-related RCC, and I certainly would not recommend that. These are good prognosis patients, and we know from the data that have come out of a metastatic setting that these are probably not the patients that are most likely to respond to that. Targeted agents, we talked about pazopanib being, yes, an option, clinical trial, sure, but I would say also, belzutifan would be something. Caveats that we have already talked about with regards to making sure we're monitoring anemia and hypoxemia. This could help this patient and help delay defer surgery.
Yeah, I would agree as well. I think this is certainly a really exciting new therapy that's become available for patients with VHL syndrome, and I think it rises to the top in my mind. Now let's move on to a second case. So we've talked about VHL syndrome associated RCCs. Let's talk about sporadic RCC. So case study number 2, we have a 60-year-old Black male patient who presents with intermediate risk metastatic clear cell RCC. He previously had surgery with a complete resection, and then had about 18 months between the nephrectomy and development of metastatic disease. He was treated with first-line pembrolizumab and axitinib, actually obtained a complete response rate, a complete response that lasted for about 10 months until the disease recurred and progressed, and was subsequently treated with second-line cabozantinib. The best response was stable disease, and he was on therapy for about 4 months. And now he's at second recurrence or progression of metastatic disease, and he'd like to discuss further treatment options at this point. So Dr. Yonesh, he comes to you. Maybe what we can do is have you talk a bit about what medical therapies are available in general now for metastatic RCC, and how that landscape has evolved over the past 15 to 20 years.
Yeah, it's rather, I think if we were to do a sort of a curve, I think there's probably a geometrical increase in the number of options, especially just if you look at the approvals in the last year or so. So frontline, in a nutshell, is mostly either IO or IO-TKI combinations, and there's 4 IO-TKI combinations and 1 IO-IO combination, and depending on whether the patient has favorable or intermediate and poor risk disease, that will really define those, which therapy you would give. Second line and beyond really is a little bit of a data, it rapidly become a data-free zone because of the fact that we have a lot of the trials in the second and subsequent line, like cabozantinib, lenvatinib, and everolimus, axitinib, we're done in the basically late TKI era, and relatively few of those patients were receiving IO agents. So what to do for an individual who's progressed on an IO TKI or IO is really in process of evolution. And in terms of agents that this patient could get, off the rack, if you will, if you progress on cabozantinib, this patient in my clinic, in terms of things that are FDA approved and available, would probably be getting lenvatinib and everolimus.
Yeah, so certainly quite a few different options available, and I think it's probably a good problem to have, in that we have so many different therapies now available, and the first line therapies have really been developed and move forward to the first line so quickly over the past few years that, as you mentioned, we don't really know, we don't have robust data to say what's the best second and third line therapy after nivolumab, ipilimumab, or an IO-TKI agent. I think one area that is on a lot of people's, one question that's on a lot of people's minds is, how does belzutifan or other HIF inhibitors fit into the management of metastatic clear cell RCC, just sporadic disease, not associated with germline VHL mutations. And so belzutifan is certainly being developed in this area, as are other HIF inhibitors. And but maybe we can have Dr. Jonas dive into the data that is available so far. So moving into just looking at belzutifan monotherapy in patients with sporadic metastatic clear cell RCC.
Yeah, thanks, Shane. This was a really, really interesting study to be involved in. And as you know, it was published in Nature Medicine this summer. It was basically a dose extension, 55 patient reporting. It did this. The paper also looks at the phase 1 portion, but it really focuses on those 55 patients. And the trial defined the recommended phase 2 dose for belzutifan at 120 milligrams by mouth daily. Although that in of itself is potentially subject to variation from patient to patient. As you mentioned, there are some glucuronidation pathways that might vary the exposure from patient to patient, and we probably have to adjust that to some degree in a subset of individuals. But this group of patients that we treated, the striking thing was they had a median of 3 prior therapies. And, we can always say, well, that means that these are survivors and those are the patients that are going to do well despite anything you do. But I can tell you, having enrolled 14 of these patients myself, that was not really the case, that these were patients that had, in some cases, pretty aggressive disease. And they were treated with 120 milligrams of belzutifan. The treatment-related adverse events that we saw with this were pretty similar to what we've just talked about for VHL disease, but we did see that there was more hypoxemia than with the VHL patient population. This makes sense. This is an older patient population, median age of 62. We do see that there was 40% of the patients that had a grade 3 treatment-related adverse event. 4% or 2 of these patients discontinued treatment due to a treatment-related adverse event. In both cases, this was hypoxemia or hypoxia. There were no grade 4 or 5 treatment-related adverse events, and 4 patients on the trial died. One from acute kidney infection, another from cardiac arrest, not really related to the study drug itself. So. And the efficacy we saw here for this trial was we saw that the objective response rate was 25%, and we saw that there was a PFS of 14.5 months. And I think that's really the most striking thing. And once again, the kinetics here were of slow reduction in disease burden over time, but not a plateau. In those who were responders, the plateau did not occur early on. So very similar, in nature to what we saw with the VHL patients. Clearly we're not, curing cancer with this, but we were providing efficacy data in this 55 patient experience that we really didn't expect to see in this heavily pretreated population.
Yeah, and I think, just one thing that I wanted to point out was in terms of the 4 patients who died on study, the other 2 patients died of disease progression. So it really didn't seem like, it seemed like the tolerability overall was still fairly good, despite an older and, metastatic disease population being treated with this drug. Now, in terms of the kinetics of this therapy, Eric, do you, just in terms of taking a while longer, perhaps, or to achieve a PR or more stabilization of disease, does that change how you view the use of this medication in your patients with metastatic disease, sporadic RCC, versus what we talked about before, the approved setting for VHL syndrome associated RCC?
I don't think it. I mean, I think we just have to look at this, and we will still do imaging in a similar way, and we're going to look at the outcomes in a similar way. But I think we just have to be patient. We have to be aware of the kinetics of the therapy relative to other treatments that we have been giving in the past.
Great. Yeah. So, I think certainly some exciting preliminary data. I think, as we mentioned earlier, there are lots and lots of ongoing larger phase 2 and phase 3 studies that are continuing to evaluate the efficacy of belzutifan for patients with metastatic clear cell RCC. And I think this particular study you just went over, led to the phase 3 study that's ongoing, comparing previously treated metastatic patients with clear cell RCC treated with belzutifan versus everolimus randomized in a 1-to-1 fashion. So that clinical trial is ongoing and accruing, and hopefully data forthcoming in the upcoming couple of years or so. Moving on to MK6482-003, this is a separate study looking at a combination of belzutifan plus cabozantinib in patients with advanced or metastatic clear cell RCC. Again, a single arm, or excuse me, essentially, an open label phase 2 study with 2 cohorts. One cohort being treatment naive, and the second cohort being patients who've been previously treated with an immunotherapy agent. And patients received the RP2D dose of belzutifan at 120 milligrams daily, plus cabozantinib at the 60 milligram daily dose. And what they saw here in terms of patients who enrolled on this study, I think pretty typical. Patients' median age was in their 60s, male to female predominance, ECOG performance status about roughly half, between 0 to 1. And these were patients who previously been treated with immunotherapy, so at least 1 line of therapy, and close to half of patients with 2 lines of prior therapy. 2/3 of patients received a combination of PD-1 plus CTLA-4 agents, and the other third, another third received treatment with a VEGF and IO combination. In terms of treatment efficacy, again, you can see here the waterfall plot shows that the vast majority of patients experience some degree of tumor shrinkage or reduction in the target lesion size. Only a handful of patients, experience some form of tumor progression or increase in tumor size as their best response. In terms of the Swimmer's plot, again, you can see here that this is early data, and a lot of patients are still ongoing or continuing with the study treatment at the time of this data presentation, but you can see that quite a few patients are making it to at least 6 months on study, and many are making it to greater than a year on study and continuing on the therapy, which is, I would say, pretty encouraging, considering you're giving 2 therapies that are combined together, going to have some overlapping toxicities, and also we know that cabozantinib at a 60 milligram daily dose is going to have some toxicities, ongoing, even on its own. What are your thoughts, Eric, in terms of this data set with a combination of belzutifan with cabozantinib?
Yeah, they're definitely, great numbers. We're seeing, but I think we need to compare this to the data that we've seen with belzutifan monotherapy. So we are seeing a numerically better PFS. We are seeing a numerically better ORR, but I think we really need to see the maturation of these data to see whether TKI, HIF-2α, small molecule inhibitor combinations are substantially superior to HIF-2α small molecule inhibitors alone. I hope they are, but time will tell with regards to further follow-up.
Yeah, I think it's an interesting question. How much how much overlap are you getting in terms of hitting this pathway, and how much additive benefit or synergistic benefit might you expect to see? Do you think there's some biological rationale for hitting HIF and hitting VEGF and obviously other tyrosine kinases in combination?
Yeah, I mean, you could imagine that you can refine that the upstream HIF-2 alpha blockade is going to take care of a number of the transcription of a number of these things, but it's never going to be perfect. So then doing what you would call sort of vertical blockade, where you're ensuring that some of the downstream effects of upregulation of HIF-2 alpha are being doubly covered, it can be logical. And it's one of these things here where, again, you can do all the preclinical modeling you want. You really need to see how this works in patients.
Yeah, I think that's a great point. As ultimately we do need a follow up and additional data from these ongoing clinical trials to know for sure in patients. So why don't we close out with a summary here? So, HIF-2 alpha blockade with belzutifan has demonstrated value for VHL mutated cancers, including VHL disease, as well as sporadic clear cell RCCs in some of these early clinical trials. The FDA did approve in August of 2021 belzutifan for the use of VHL disease-related RCC, hemangioblastomas, and pancreatic neuroendocrine tumors. There's encouraging data that's emerging in advanced sporadic clear cell RCCs, as we just talked about, with phase 1 monotherapy data, as well as phase 2 combination therapy data with cabozantinib showing activity and response rates in the mid 20% range, as well as progression-free survival and reasonable tolerability data. There's robust clinical development underway in a number of different disease settings, and with a number of combination partners, as well as in monotherapy for advanced clear cell RCC, both in second line and beyond setting, as well as in the first line setting. I'd be remiss if I didn't point out that this is really an evolving field, as you can get a sense of, with a number of other companies really trying to develop HIF-2 alpha inhibitors for clear cell RCC. So belzutifan is only one of several agents targeting this pathway. DFF-332 is another agent from Novartis, another HIF-2 alpha small molecule inhibitor that's opened up in phase 1 evaluation as single agent, as well as in combination with everolimus or spartalizumab, which is an anti-PD-1 inhibitor, and an adenosine receptor antagonist for clear cell RCC. That's for sporadic disease. And then ARO-HIF-2, which is another agent targeting HIF-2 alpha, this through RNA interference, so RNAi agent. And this is a phase 1 study that's ongoing with very early preliminary data, I believe being reported in a press release recently, stating that at least one patient did have a partial response, and an additional 5 out of 7 patients reported so far had stable disease. Other agents, I believe, are under development as well. And Eric, I'm curious about your thoughts on this field. Is this something where we're going to see development of additional agents? Are they going to be, is it going to be a similar arena as the TKIs, where we have multiple agents where we may be able to rotate through some of them, where if a patient has poor tolerability to one or has disease progression to one, that it's reasonable to rotate to another agent in the same class?
Yeah, I think the answer is definitely possibly, and that's really going to be a function of what the mechanisms of resistance are and whether or not these agents have complementary mechanisms of action. I think, for example, the ARO-HIF, the antisense agent or interference agent, that is different. So, you could imagine that agent would potentially be able to pick up where some sort of a mutation in the PAS-B domain were to come to pass in a tumor or something like that. And then also, the small molecules, as we've seen with all of the TKIs, something that ostensibly interacts with the same receptor doesn't necessarily act exactly the same way. So I think the shorter answer is yes, and I would expect that there's going to be a proliferation now that we see from a small molecule perspective and also from a proof of principle perspective that this is a very reasonable targetable pathway. Undoubtedly, we're going to see a number of players in this space.
Yeah, certainly, an exciting new, arena for new therapies for renal cell carcinoma. So let's get back to case study 2. So again, just as a refresher, this is a 60-year-old Black male who has a metastatic intermediate risk clear cell RCC, previously treated with surgery, pembrolizumab, axitinib, and then cabozantinib with recent disease progression. And so, Eric, the patient comes to you for an opinion about, what are his options at this point? Does he try a different immune checkpoint inhibitor or combination? Are there targeted therapy agents, other TKIs, or perhaps mTOR inhibitor that you would suggest, or clinical trials if he were coming to you today?
Yeah, I would definitely try to get this patient onto a clinical trial if we had one available. There is a study that's underway looking at, for example, belzutifan plus lenvatinib versus cabozantinib. I think that would be a really interesting study for the patient to be on. Off study, as I mentioned before, I think lenvatinib everolimus would be a very reasonable option for this patient. But clearly, this is a sort of individual that we would want to prioritize a clinical trial for.
Excellent. So let's move on to the SMART goals here. The first SMART goal is that clinicians should be aware of the data supporting the use of belzutifan in patients with VHL mutation-driven disease. Certainly, this is a new approval and an exciting new option for patients with germline VHL mutation-driven disease. Clinicians can encourage their patients with previously treated clear cell RCCs to participate in clinical trials that give access to emerging therapies. So as we showed earlier, there's exciting preliminary activity in sporadic clear cell RCCs. And then finally, clinicians should be aware of the toxicity profile of belzutifan and how to manage them with this new therapy that I think we're all coming to become more and more familiar with. So thank you so much, Dr. Yonash, for that very interesting discussion. I'll wrap up. Please remember to collect credit for this activity by using the Apply for Credit button on your screen. And please visit the CME Outfitters Oncology Hub to access additional activities that will enhance your care of patients with cancer. Thank you again for joining us today, and thank you for your care of your patients.